On behalf of the Pennsylvania Patient Safety Authority, I'd like to welcome you to the web conference, Preventing Falls in Pennsylvania, Implementing Best Practices and Measuring for Success. My name is Vicki, and I'll be your coordinator for this program. Today's web conference is 1 hour long and will be recorded. The slides are available and can be downloaded by clicking on the free paper icon located in the upper right-hand corner of the screen. I will give you instructions for submitting questions just before the question and answer portion of the call. If you accidentally exit the audio portion of the webinar, you can call back into the audio conference line using the number already provided to you. Likewise, if you accidentally exit the webinar, you can log back into the meeting from your internet browser. If you are having a problem logging onto the webinar, please contact the Authority support staff using the contact information listed on your registration confirmation materials. Now I'd like to introduce Michelle Feil. Michelle is a Senior Patient Safety Analyst with the Patient Safety Authority and is the lead analyst for the CMS Hen Falls Reduction and Prevention Project. Michelle, now I turn the program over to you.
Thanks, Vicki, and welcome everyone. Thank you for joining us for this web conference on Preventing Falls in Pennsylvania, Implementing Best Practices and Measuring for Success. The objectives for today's webinar are listed on this slide and the next. By the end of the presentation, we expect that you'll be able to identify the evidence-based falls risk assessment tools used in inpatient and outpatient settings. You'll be able to describe how pairing that risk assessment with other tests may further contribute to decreased falls and falls with injury, define a standardized approach to implementing evidence-based prevention strategies, outline methods for measuring processes and outcomes related to inpatient and outpatient falls, and describe specifically how the falls event type decision tree may improve information you collect to populate the PACERS Falls dashboard in the Pennsylvania Patient Safety Reporting System, that is. So we'll begin with best practices in falls risk assessment. This quote from Hillary Clinton has a balanced view of risk assessment. Often we overstate risk, especially when it comes to preventing falls in our most vulnerable patients. And we know that if we try to go overboard in preventing falls in patients who are ill and immobilized, who need to get up and move, we're going to end up keeping them in bed, otherwise restricting their mobility, and we could have unintended consequences that are very serious. So we want to avoid that also. We don't want to overstate the risk and not get these people moving. We want to increase their mobility and keep them safe. So Hillary said it best. We need to calculate the risk correctly. Let's not overstate it or understate it. Risk assessment is not a once-and-done task. It's a process. While risk assessment in and of itself doesn't prevent falls, it is the necessary first step in identifying a patient's risk factors so that those patients at risk can be quickly identified and a plan of care for prevention can be developed. Risk assessment should be repeated at intervals defined by your institution and most certainly following any status change and following any fall. So who says that falls risk assessment is a priority? It's not just professional organizations that have issued evidence-based guidelines. This is a Joint Commission requirement. It began as a national patient safety goal in 2005, and you can see that by 2010 it was upgraded to a standard of care with 2 elements of performance. You have to assess and manage the patient's risk for falls, and you have to implement interventions to reduce falls based on that risk assessment. Since 2004, the Joint Commission has been tracking the root causes for all sentinel events resulting in death or permanent loss of function. So here you can see the root cause most often identified for falls that result in death or permanent harm is in the assessment category. That's the tall blue bar on the left side of the chart. This doesn't just refer to the lack of use of a falls risk assessment tool. It includes any failure in assessment of patients that contribute to these most injurious and deadly falls. When talking about falls risk assessment, most of us automatically think of the falls risk assessment tools. Though you'll find some researchers criticizing the use of these tools, they do serve a purpose. And as I said earlier, they are the initial first step in quickly and efficiently identifying a patient at risk for falls. And they certainly fit nicely within the new concept of high reliability organizations, because these tools are tools that translate a complex process into a simple standard process that can be applied reliably and with consistency. But the tools by themselves don't prevent falls. They only predict them. Any predictive tool is measured for accuracy in two ways, sensitivity and specificity. To put it simply, sensitivity is the ability of the tool to identify positive results. So a sensitive tool is going to identify the patients at risk to fall. Specificity is the ability of the tool to identify negative results, meaning if they score low risk or no risk, that really isn't a person that you need to worry about. So falls researchers have measured sensitivity and specificity for their tools in a very controlled manner, and you want to look for high sensitivity and specificity in the tool you're using at your organization. But I want to warn you, if you are testing for this in your own organization, it can be tricky. If you specifically are looking at specificity, you have a tool that you're using, patients score no risk or low risk, and then you look and see whether they fell or not. Perhaps they're not falling because you did, or your staff did exactly what they were supposed to do. They put the right interventions in place and prevented a fall. So it can be very hard for you in clinical practice to measure this yourself. That's why you really have to go back to the original research and see what the researchers have established for sensitivity and specificity for these tools. When you see what's out there in the literature, it can really vary between fall risk assessment tools. Regardless of the tool that you're currently using or your process, you have to be aware of the risk factors that researchers have found most predictive of patient falls. Dr. David Oliver is a physician in the UK who's done a lot of research on falls, and he found in his meta-analysis that these 6 risk factors listed on this slide at the bottom were included in most of the tools that had sensitivity and specificity greater than 70%. Not all tools assess for all these risk factors, and I will discuss each of these risk factors in further detail once we move beyond the tools themselves. So here's a list of some of the tools you may have heard of. I've highlighted the first 3 because these have been the most researched. I think most people recognize the Morse Fall Scale, developed in the 1990s by Janet Morse. It's in widespread use across the United States. The Stratify tool, developed by Dr. David Oliver, is more in use in the UK, and those two have the best documented sensitivity and specificity. The Hendrick tool is another tool in common use in the United States, developed by Ann Hendrick. She developed it in an acute care setting with a diverse patient population. It has been tested for validity in other settings on a limited basis. And the Johns Hopkins Fall Risk Assessment tool, I want to point out because we've heard several hospitals in Pennsylvania are trying this tool. It was developed in 2003 at Johns Hopkins, and it has been evaluated for content validity and acceptability for clinical users, but only in the adult clinical care units where it was implemented, and the authors of the tool acknowledged that further testing is necessary. This is a table we've developed just to show you the Morse, the Hendrick, and the Johns Hopkins, since we know these are 3 of the tools reported as being in frequent use in Pennsylvania. And it takes the 6 risk factors mentioned in Dr. David Oliver's research at the top of this slide and shows you whether those 6 risk factors were specifically included in these 3 tools. And then any other risk factors included in the tools are listed at the bottom. And so why do these differ? All the developers of these tools will explain that they built their tools based on a retrospective analysis of patients who had already fallen. They looked backwards for common risk factors that predicted the falls. And some tools can assess for risk factors using different ways to get there. For instance, high-risk medications. You can see here that the Morse tool doesn't screen directly for high-risk medications. But Janet Morse explains that when you screen for a secondary diagnosis, this is a proxy for polypharmacy. It doesn't matter what the second diagnosis is. If a patient has one diagnosis, that's highly correlated with being on multiple medications, which in itself increases falls risk. I also want to point out, since the Morse tool is the most frequently used falls risk assessment tool, that the IV heparin lock field is often misscored in clinical practice. This is not just an IV that's connected to IV tubing that restricts motion and can be a tripping hazard. It's even just a hep-locked IV. And perhaps it is because the necessity of having an IV hep block ready to use is a secondary indicator that the patient has other risk factors for falling because they are so ill that they require an IV. So you really need to go back to the original literature to understand why these tools were developed to have the risk factors included that are included and why perhaps some that you think should be there are not there. Pediatric risk assessment tools. There's less published about these tools, but we thought since we know children's hospitals and rehab centers are certainly participating in some of our improvement projects in Pennsylvania, and you're probably on the line today, that we want to just mention some of the tools that are out there. If you're interested in learning more about these tools, there's a link here included at the end of the presentation to an article that is an excellent review from the Journal of Pediatric Nursing that discusses each of these tools. As for assessing risk for falls in outpatient areas, we've searched for information on risk assessment tools, but there are no specific tools that have been developed and tested just for outpatient areas. What we find is that outpatient areas are usually screening for a history of falls and perhaps using one of the mobility tests that are listed here. I'll be discussing these tests. Again, when using any risk assessment tool, you need to make sure it's working in your environment. And when any risk factors are identified, they have to be paired with interventions. And because our goal is to prevent falls with injury, it's time that we began to pair these falls risk assessment findings with other screening tools and assessments that can target our attention to patients with the highest risk of falling and falling with an injury. This will be done by using mobility tests, which are also referred to as functional assessment tools, and utilizing an injury risk algorithm. So here are the mobility tests I had mentioned. The two in common use are called the timed up and go and the get up and go. The timed up and go, you instruct the patient to rise from a straight back chair without using their arms. They walk about 10 feet, turn, come back to the chair, you time them. Adults without balance problems can perform this test in under 10 seconds. Adults who require more than 14 seconds are at the highest risk of falls. The get up and go is a longer test. It requires 5 minutes to administer, and specialized training is required to administer the test. You start with the timed up and go, and then they have to perform extra maneuvers, such as closing their eyes, and you try to throw them off balance and see how they respond, or you watch their gait as they walk. Many specific observations included in the get up and go. Ann Hendrick looked closely at the get up and go and found that just one step in the test, just observing someone rising from a chair, gives you a statistically significant predictor of falling. So there's no walking, no timing, no extensive testing. So this is what she included as one of the steps in the Hendrick fall risk assessment tool. A patient who's able to rise from the chair in a single movement without using their hands is a no-risk score. And you can see here that patients who need to use their hands or who require multiple attempts to rise or who are unable to rise, each of those steps increases your risk and likelihood of falling. And the odds ratio here means, for example, that a patient unable to rise is over 10 times as likely to fall as a patient who can rise in a single attempt without using their hands. Adding injury risk assessment to falls risk assessment is a strategy that would be labeled one of the more innovative areas in falls prevention. Assessing for injury risk is independent from assessing the falls risk. A person with risk for injury is at risk for injury from any number of causes. Someone at risk for bleeding would be at high risk for bleeding from any cause, not just due to a fall. A person with weakened bones is at risk for fracture from any blunt trauma or even normal weight-bearing activities. But when you crosswalk these risk factors for injury with risk factors for falls, you'll identify the patients at highest risk for falls with serious injury, and that is the group we need to target for prevention and protection. Referred to as the ABCs, you can see what they stand for on this slide. You may be thinking that protecting people from injuries would just be about floor mats, hip protectors, helmets, but it's not. Pat Quigley and her colleagues at VHA highlighted application of the ABCs in research that targeted reducing falls with injury on med-surg units. they did use the protective equipment, but they also identified other interventions that were effective in decreasing specifically falls with injury, and those were interventions such as teach-back, toileting prior to pain meds, safety huddles after a fall, and different types of rounding. So it's not just about the protective equipment, and I encourage you to read more about this research in the TCAB guideline. There's also a link to that at the end of this presentation. Is use of a fall risk assessment tool really an assessment? They may be more accurately described as screening tools. There are some interventions that can be initiated as soon as you have results from the use of a risk assessment tool, but an effective individualized plan can't be developed without further in-depth assessment. So there is some controversy over whether you should call these tools assessment in the first place. Truly, the tools are an initial screening. Moving beyond the tool, you want to assess these individual risk factors. You're going to recognize some of them from the risk screening tools. We've included this just for your information so that you can see the relative risk of falling that is associated with each of these individual risk factors. So again, relative risk means someone with a visual deficit is 2.5 times more likely to fall than someone without a visual deficit. So that's how you can read this chart. And the two that correlate highest with fall risk are muscle weakness and history of falls, with gait deficit and balance deficit coming closely behind. Other research has revealed the profile of a patient at greatest risk of falling to be someone with cognitive impairment. The person who did this research also included depression in the definition of cognitive impairment. History of previous falls, impaired mobility, special toileting needs, advanced age, medications that act on the central nervous system. There are also risk factors common to many hospitalized patients at risk to fall. But they don't rise to the level of the first four. Those first four are really highly correlated with patients falling. We're going to talk about them one by one. First, cognitive impairment. There's a clear link between increased falls risk and delirium and dementia, especially when agitation and wandering behaviors are exhibited. However, there's also evidence that decreases in just global cognition and slow cognitive processing speed also increase falls risk in older adults, even without a diagnosis of delirium or dementia. You may have noticed on the earlier slide that the Hendrick 2 tool does assess for depression as a risk factor. And in the other slide showing you individual risk factors with their relative risk, depression was shown to increase the risk by more than double. Use of antidepressants, especially the SSRIs, has been found to have a strong association with falls and falls with injury, but even apart from that medication use, just symptoms of depression have been found to be independent predictors of falls. A diagnosis and antidepressant use is not required to demonstrate this risk. In fact, a patient with a history of depression who isn't displaying these symptoms of depression wouldn't be considered at risk, especially when using the Hendrick 2 tool. She will specifically tell you without the symptoms, they don't score positive for depression as a risk factor because their depression would be considered to be under therapeutic control. History of falls has been found to independently predict future falls. It has a relative risk of 3, meaning those who have already fallen are 3 times more likely to fall again. And in most of the literature, you're going to find 12 months used as the cutoff, but we do know that some groups, such as the Johns Hopkins groups, use 6 months as the cutoff. In many outpatient settings and ERs, screening for history of falls has been accepted as the only form of falls risk assessment. Because history of falls and impaired mobility carry the highest relative risk of falls, screening for these 2 risk factors is often recommended as just a simple and effective risk assessment method in your outpatient areas where all your patient encounters are time limited. Impaired mobility. Muscle weakness can more than quadruple the risk of falling. The relative risk ratio was found to be 4.4, and gait speed and stride length decreased markedly beginning at age 85 for women and age 90 for men. Slower gait speed has been found to significantly correlate with increased falls. In patients without a history of falling, Just screening for balance and gait problems significantly predicts future falls more than any other risk factors. Toileting. Studies evaluating the circumstances of patient falls in the hospital setting have estimated up to 50% to be associated with toileting or other elimination concerns. And we believe that this could actually be much higher, and I think those of you in clinical practice would agree. Toileting-related falls have also been found to significantly increase the risk of fall-related injuries. Those falls that occur in and around toileting are usually the most injurious. Advanced age. Risk for falls and falls with injury, we know they increase with age. Adults over age 80 are in the highest risk group. And according to data from the CDC, falls are the leading cause of injury deaths in adults over age 65. Death rates from this are rising sharply. And even if older adults survive the immediate effects of a fall with hip fracture, 20 to 30% of those still die within a year of the injury. I've included a link here to the CDC website with more data on falls in older adults. This information is a great starting point for making the business case for increased resources being dedicated to a falls prevention program at your hospital, especially with our large growing population of older adults. Okay, medications. This is quite a list. It really could be longer, depending on how you want to look at meds associated with higher risk of falling. Older adults are more prone to the adverse effects of medications due to changes in their metabolism or slowed clearance of the drugs from their system or drug interactions. They tend to be on more medications. But just being on 4 or more meds in and of itself increases the risk of falls. It could be because of the effects of the drugs or the interactions, but it also could be in part because patients who require that many prescription medications have acute and chronic conditions that are also putting them at high risk to fall. In fact, last year in a study in the Journal of Injury Prevention, they looked at young and middle-aged adults and found that those using at least 2 medications had an increased likelihood of dying from or being hospitalized for a falling injury. And the medication class in that young and middle-aged adult group, they were antihypertensive and cholesterol-lowering drugs. So you want to know, is it really the effect of the medications, or would this make you tend to believe it's because of the conditions that these medications are treating? That there's the problem in looking at how medications impact fall risk. So whatever the case may be, this is a very clear example of why you need to have pharmacy actively engaged in your interdisciplinary falls prevention team efforts. This slide shows the frequency with which falls risk should be reassessed. In post-fall investigations at Ascension Health, Ann Hendrick mentioned that failure to reassess falls risk with a change in patient condition was one of the root causes they found for many of their falls with serious injury. There's strong evidence to support performing a post-fall reassessment of patients, and these are the items that should be addressed, as identified by researchers in this area. Multiple guidelines strongly recommend these post-fall assessments. 3 of the guidelines listed at the end of the presentation today with links have sample post-fall risk assessment tools and investigation forms that are freely accessible to you. I encourage you to check them out. And these post-fall assessments serve 2 purposes. You want to modify the plan to prevent a repeat fall for this patient, and you also want to identify trends that you're seeing in falls across your institution that might help you to reshape your efforts across the hospital. That's it for risk assessment, and I just want to touch briefly upon some fall prevention strategies. Before jumping right into the interventions, I want to remind you that organizational support and leadership are key. Interventions by themselves are just one component of a falls prevention program. This slide shows the key components as defined in the VHA guideline. And because we want to offer you interventions based on evidence, we've used this evidence grading system to let you know what level of evidence supports each intervention. Level 1 being the highest. That research includes systematic reviews of very high-quality studies. Level 2 are the single experimental studies, and you can see that the the grading levels go down to level 6, which would also include, excellent recommendations and opinions of respected authorities or consensus panels on the subject. I want to orient you to the way I've laid out the following slides. And at the top, you'll see the level of evidence supporting this component. And at the bottom, you'll see the falls prevention guidelines, which speak most specifically about this component. The abbreviations for the guidelines refer to the organizations that are listed at the end of this presentation. And all of the guidelines used in developing this webinar are freely available online. So, organizational support and leadership. They are absolutely fundamental to any falls prevention program. Researchers have found greater success in facilities where leadership has made a clear statement that falls reduction is a priority that they support. But Cameron warns us in a Cochrane review from 2010 that without additional resources, programs could actually increase falls rates. And why is this? Well, in one study, patients in their intervention group were nearly 3 times as likely to fall when compared to the non-intervention group. And they thought this was perhaps because they pulled a falls champion away from their normal assignment, or they provided an exercise intervention that made these patients more likely to think that they could get up on their own, more confident and strong, but then they were not covered with extra staff to replace that falls champion that was pulled away, or there wasn't sufficient staff to respond quickly or to provide rounding to prevent patients from trying to get up on their own. Several studies have looked specifically at implementation of falls prevention programs that are multidisciplinary, and there is suggestion that these programs are more effective in reducing falls and falls with injury compared to other programs that are traditionally more dependent on nursing alone. There are clinical and non-clinical staff who have not been engaged in the design of falls prevention programs, and that's not always because they choose not to be involved, but because we haven't invited them to the table. And one message that must be sent by your organization's leadership is that falls prevention is everyone's responsibility. So if you're chartering a new falls prevention team or task force, it's the perfect time to demonstrate this for your entire staff by inviting in disciplines that haven't been involved. Non-clinical, administrative staff, people who themselves may be uncertain how they can impact falls reduction in your facility. They need to be included. Multifactorial interventions have the highest level of evidence from some pretty big meta-analyses of the research. You'll find that some researchers out there have done systematic reviews, and they say there's no evidence to support any falls prevention programs. But this is what we know from our review of the literature. Interventions have to be multifactorial, and they are perhaps most effective when delivered by an interdisciplinary team. Pardon me. Standard falls prevention interventions, these should be very familiar to all of you on the call today. You'll notice that these are interventions targeted to extrinsic risk factors, mostly environmental risk factors. I'm not going to go through each of these in detail. This slide should be more of familiar standard interventions for all patients, not just those at risk for falls. Now we get into some of the special things perhaps you've already been doing at your facilities, such as using special visuals to indicate the falls risk of a patient, providing cued toileting as a part of purposeful rounding, perhaps, hourly rounds, you may call them. And staying with patients in the bathroom is being required in more and more places because of the high number of toileting-related falls being recognized, or falls from commodes. Use of safe patient handling techniques is geared toward preventing that unexpected fall when you're trying to transfer a patient or mobilize them. As an added bonus, it should help protect staff from hurting themselves as well if these safe patient handling techniques and devices are used properly. And the rest of these I'm going to talk about in a little more detail. Hourly rounding. In a systematic review of studies focused just on hourly rounding as it impacted falls, falls decreased in 7 of the 9 studies. In some of the original research by Shirley Mead and Pat Quigley, they found hospitals who had implemented hourly rounds along with toileting, which some are calling purposeful rounds, In those hospitals, they were able to decrease their falls by 60%. And other benefits attributed to rounding are listed here under the results bullet. The top two reasons patients fall are twitching and reaching. So you can see how purposeful hourly rounding can meet those patient needs before they result in a fall. Alarms. They can be helpful in patients with cognitive impairment. There's some level 5 and 6 evidence to support their use. If you are using alarms, you have to be sure staff are trained in setting alarms or applying the devices according to the manufacturer's instructions. Beds with built-in alarms usually require you to zero the built-in scale before placing the patient in bed, and some have varying zones of sensitivity. So sometimes the most restrictive zone would give you a lot of false alarms whenever the patient just shifts weights or turns in bed. So you have to customize the alarm settings for each patient based on their risk factors. Seatbelt alarms can be quite effective since they sound as the patient is starting to think about getting up and they remove the belt. But you have to use caution. If the patient is physically or cognitively unable to release the belt, that would be considered a restraint. So you need to have the patient demonstrate how they're going to remove the belt before you use something like that. And another word of warning when using alarms in patients who are cognitively intact, you and your colleagues may disagree as to whether a patient warrants an alarm. And a cognitively intact patient who has been educated about their falls risk, but who continues to be impulsive and gets up by themselves without calling for help, can be a real challenge. So often we know these situations are not black and white, and patients can become very insulted by staff who insist that they wear an alarm. Alarms for everyone is a strategy proposed by some, but we're just not sure that that would jive with patient-centered care. So you have to use caution when developing guidelines for when alarms are to be used, especially with your cognitively intact patients. Low beds are generally defined as beds that must get within 8 to 10 inches off the floor. A Cochrane review from 2011 showed no significant increase or decrease in the rate of injuries or falls from low beds. However, even though that was a systematic review, there were only 2 studies that could be included in that review, and they had small sample size. So there's a lot more research that needs to be done. And sometimes it's hard to tease out the effect of the beds. In the research at Ascension Health, low beds were placed across the health system on all units. They decreased their falls by 9%, but how much of that was due to the beds and how much of that was due to other interventions included in their initiative? Sitters, another area of contention. Continuous observation, one-to-one, sitters, whatever you want to call it. It's expensive to provide staff to provide this service. The conclusion of Harding's systematic review was that, there's no research to support their use. And we know in today's cost-cutting, cost-conscious, value-based purchasing environment that administrators are really looking at the sitter programs to make sure they're absolutely worth their costs. So you're going to have to make the business case, and if you are making adjustments to your sitter program, watch those balancing measures. Does restraint use start to go up? Does your falls and falls with injury rate start to go up? You have to make the case that it's worth the investment. And then there are evidence-based guidelines for who should be providing the service and how they should be trained and what exactly they should be doing when they're in the room with the patient. Communication. We can divide this into communication to patients and families, communication to the healthcare team. Here are some of the visual communication tools that you're probably already using. I've put some of the familiar icons there, the Ruby Slipper program, the red falling leaf, the falling star. You want to be cautious of sign fatigue. However, you can become blind to the signs, but the signs are really there so that people, any person, even non-clinical or visitors who know what that sign means can instantly recognize that the patient is at risk to fall when they see that color or they see those red socks or they see that sign and intervene. And I can't tell you how many reports of falls prevented by environmental services staff we have seen where this person doesn't know the patient, but because they saw the sign, they were able to intervene and prevent a fall. So you want to educate everyone as to what these signs mean so that everyone can intervene. Obviously, risk factors and prevention measures need to be communicated to patients and their family members. They are part of your fall prevention plan. Education has to be geared to the patient and family's health literacy level, their learning style, and their identified needs. And we have heard a lot about teach back. Teach back is where you ask the patient and the family to teach what you've just told them about preventing a fall back to you. Tell me how you're going to prevent a fall. Tell me what you're going to do when you need to get up and go to the bathroom. A very effective strategy for educating about falls prevention. Here are some of the tools that perhaps some of you have been using to standardize communication. We know that things fall between the cracks during handoffs, and when patients move from one area to another, or one care provider to another. So communicating that falls risk and what steps need to be taken to prevent a fall has to be done in a standard way, and these are just some of the tools that are out there. We've covered quite a bit of information today regarding best practices in falls risk assessment and prevention. Assessing progress with improving these processes and measuring compliance with your falls prevention practices is absolutely vital. And Dr. Leanne Gardner now will walk us through some of the ways that we are doing this in Pennsylvania. Leanne?
Thank you, Michelle. I'm going to start by showing you some information that was discovered when looking at the PACER Falls Risk Assessment reports. What we found was that there were gaps in the falls processes of risk assessments, identification of patients at risk for falls, and prevention strategies in place. So the authority developed a set of falls reports for a falls reporting program, and today we're going to talk about the development of the falls dashboard and the process measure reports. But I also want to let you know that there are inpatient and outpatient falls reports with benchmarking data. Hospitals need, though, to enroll in the PACER's falls reporting program to be able to obtain these reports. Now, here are words from a song by the band Florence and the Machine that fits today's webinar. It says, sometimes I wish for falling, wish for the release, wish for falling through the air to give me some relief. Because falling's not the problem. When I'm falling, I'm in peace. It's only when I hit the ground, it causes all the grief. In order to, if you have any questions regarding the PACERs, please contact the PACER Help Desk. For all other questions, please contact the Patient Safety Authority. And that concludes our slide presentation. Thanks again for joining us. This concludes our webinar.